Welcome, everybody. We're really excited this morning to have Doctors Prasad, Kostantinis speak to us on their recent article that highlights disparities in care between women and men in a really wonderful, insightful article called Gender Differences in Chronic Total Occlusion Percutaneous Coronary Intervention, Insights from the PROGRESS-CTO Registry. We're grateful to have Dr. Cader, who will be moderating our webcast this morning. Dr. Cader.
Thank you very much, Dr. Sigurwa. Welcome both Drs. Prasad and Kostantinis. If we could kick off the discussion of this paper, which was published in CCI in October 2022. Dr. Kostantinis, would you summarize for us what this study set out to do, and also perhaps the demographic aspects or characteristics of the sex differences in this study?
Yeah, thank you so much, first of all, for the invitation, for having us here today. So in the study, we included more than 9,000 CTO PCIs performed at 38 centers between 2012 and 2022 in the PROGRESS-CTO registry, which is an international multi-center observation and prospective registry. In the study, we included 81% were men and 19% of the patients were women. Regarding patient characteristics, compared with men, women were older, had higher BMI, and were more likely to have comorbidities such as diabetes, hypertension, and peripheral arterial disease. Women were also less likely to have had prior MI, prior PCI, and prior CABGs as compared with men. The majority of patients in both groups were symptomatic and presented more commonly with stable angina. However, women were more likely to present with unstable angina or NSTEMI compared with men. Regarding angiographic characteristics, the most common CTO target vessel in both groups was the right coronary artery. However, the LAD artery was more frequently the target vessel among women. CTO lesions, lastly, regarding angiographic characteristics, CTO lesions in male patients were longer and more complex with unfavorable characteristics, and as a result with higher JCTO score as well as PROGRESS-CTO score.
Thank you. Thanks so much. So you did mention that women had less complex CTO characteristics despite being older with more comorbidities. Were there any sex differences in the procedural or technical characteristics and also the outcomes that you looked at?
That's a great question. Thank you very much. Regarding technical characteristics in female patients, undergrade wiring was more frequently the initial as well as the final successful crossing strategy compared with men. And on the other hand, more complex CTO PCI techniques such as the ADR approach and the retrograde approach were more frequently used in men. Another interesting finding is that interventions in men required longer procedure time and fluoroscopy time, as well as higher air camera radiation dose and contrast volume compared with men. Regarding outcomes, technical and procedural success rates were higher among women. However, in hospital MACE was also higher in women, was overall 2%, but was higher in women, 2.9% versus 1.8% in men. Overall, in hospital mortality was low, was 0.5%, and was similar in both men and women. But the incidence of tamponade required pericarditis and vascular access complication was higher in women. However, there was no significant difference in the incidence of perforation. When we did also a multivariable analysis, even after adjusting for multiple clinical and angiographic factors, female sex was independently associated with higher technical success, but also with higher MACE.
Thank you so much for that very in-depth report of the results. Perhaps we could ask Dr. Prasad whether there were any explanations for these findings. I mean, despite better technical and procedural success, women still had more in hospital MACE. How would you explain this?
Yes, I think this brings a very interesting point. So when we were looking at the data, we sort of dove further into it to try and understand why that may be. And so we know that women tend to have more vascular complications, and you'll see that radial access was used less frequently in women than in men in this data set. And that's, one thing that we need to keep in mind. The reason for that is most likely that with women, especially given that you're going antegrade, you may be using a larger guide, and women tend to have smaller arteries, vessels that spasm more easily. And so operators are often more reluctant to put in larger guides. And so biradial is less common in a woman than it is in a man. But it's also important to understand that the perforation rate was different between women and men, and the perforation rate itself was similar, but the degree to which the perforations affected the patient was more. And so I think it's important to understand that, because women tended to have more tamponade, more need for pericardiocentesis than men. But we also know that women had more of an antegrade approach than men. And so the thought is, and we're going to look further into this, is that these were more likely large vessel perforations requiring more work, essentially. So sometimes they needed a pericardiocentesis, sometimes they needed even more aggressive care to try and address those large vessel complications. These patients also tended to go more antegrade in female patients than in male patients. And that's, again, an important characteristics, because when you go antegrade and you push to go antegrade, you're sometimes using more aggressive wires. And if you're reluctant to switch to a retrograde approach, while retrograde approach is associated with more complications, you can cause worse perforations being more aggressive from an antegrade approach. And so we're going to delve into that a little bit more to understand that. But this manuscript really shed light on a lot of these different findings. I think the vascular access is a big one, and then the difference in the degree of effect of the perforation on the patient, I think, is another thing that we learned from this.
So, Dr. Prasad, thank you so much for highlighting some of the potential etiologies for the increased rates of tamponade in women as compared to men. So when I think about, what I've heard today, clearly the ability to treat women with CTO techniques and have success is at least equal to, if not greater. There are differences in the CTO scores, but it's clearly an efficacious procedure. However, I do note the signals of potentially excess harm, as you mentioned, vascular complications, bleedings, numerically a higher rate of stroke. What are your thoughts about the safety profile of CTO in women? And are there things that we as operators should be cognizant of that you might suggest that we keep in mind?
That's a great question. So I think, first and foremost, this is not, our cohort is only 19% women. And so it's a very select population that are even being offered CTO PCI. And so the question is, we know that these women often have, increased age, increased comorbidities, but the question is, are we offering this to patients that are sicker or more symptomatic, or is it taking us longer to offer this procedure to these patients, and does that change the substrate? So that's sort of a limitation of our data set. But I think the signal is certainly there, and I think we need to think about things that are different in women versus men. And first and foremost, their arteries and they are smaller than men's arteries. And so I think we have tools like intravascular imaging that we need to use aggressively. In our cohort, we did find that imaging was used more frequently in women, but it's important that that be used, especially to avoid large vessel perforations or oversizing balloons, but also to improve the durability of the procedure, to make sure that we're sizing these stents appropriately and not putting 225 stents in a CTO of an LAD in a woman only to realize that that's going to restenose later. So I think we need to understand that there could be a potential increased risk in women, but I think that can be mitigated, like you mentioned, by being extra careful and practicing good CTO PCI hygiene. So we're going to approach these patients antegrade, checking in 2 different views to make sure that that wire is where you think it is before you advance a microcatheter, to use intravascular imaging to check the position of your wire. So just sort of increase your tool set as an operator so that you're more safely taking care of these patients, recognizing that there's an increased risk in men and women, but with women, there's certainly the bleeding risk that has been shown not only in CTO data, but also in PCI data in general, and to sort of really be doing whatever we can to mitigate that, but to not let that come at the cost of offering patients these procedures, which can help them improve their symptoms.
Thank you.
Thanks, Dr. Prasad, for those really pertinent points. And I think what's nice about the study is that it's quite contemporary. You did mention about the uptake of radial, which is close to 50% in men, although less in women. There was IVUS data as well, which isn't really reported in the other sex-based analyses of the CTO registry. However, you very pertinently also pointed out that women comprised only 19% of this cohort. And this is consistent across all CTO registry-based analyses, because the CTO registry from Europe that was also published in CCI earlier this year comprised of a female cohort of about 15%. So we clearly have a problem of underrepresentation in registries, be it selection bias or whatever it is. But what do you see as the biggest challenges in female participant recruitment, particularly pertaining to CTO PCI?
Yeah, that's a great question. So you're right. This is a real challenge that our field as a whole faces, but especially in CTO PCI, we are noticing that there's less women in these registries. And there's a variety of things that may contribute to that. It could be differing presentations when compared to men. Women are thought to have more shortness of breath rather than chest pain. It may be due to some of the factors we've seen, just in terms of the fact that women get PCI less than men despite having ischemia or despite having symptoms. And that has been shown to be because women spend less time on their appointments and their health than men, as they assume a caretaker role. But it can also be secondary to a difference in the way we offer these procedures to women versus men. And so I think there's a need for us all to be mindful of this discrepancy and this disparity, and to see what we can do to make sure that when we assess those female patients, we're offering them the same treatments that men are and eliciting other symptoms. So not just focusing on chest pain, but also understanding fatigue, understanding shortness of breath, understanding that maybe a woman has started doing less than they used to before and aren't volunteering that information. So I think it starts with, good medicine and a good history. But there's a need for us all to be mindful of this and partner to reduce this disparity. It starts from our initial interactions with our female patients, but it goes all the way to the post-procedural care and the follow-up to make sure that these women are followed appropriately. I think it's also time that we start to have trials that are dedicated to women, which will help not only raise awareness, but also help us as a field understand how we're going to recruit women to complete those trials. The Empower study is one that will be starting, which is looking at calcium modification with intravascular lithotripsy in women. And I think trials like that are focused on women will help us improve the data we have for complex coronary disease, specifically in this subset.
Thank you.
Wonderful. Doctors Prasad and Kostantinis, I really want to congratulate you and your co-authors for continuing to pursue the scholarship that really demonstrates several key findings. And the first is there is clearly a referral bias that disadvantages women relative to men. And this is consistent across all publications to date that we've seen in the CTO, and provides us the opportunity, as you mentioned, to better understand the symptom complex and the potential areas where physicians, including interventionalists, may have some deficits in understanding the symptom complex that may represent ischemia, or particular biases in how we treat individuals. So clearly an area that we need to better understand to close this gap. Second, I think this manuscript clearly demonstrates that the ability to treat CTOs in women is present with high procedural success rates. And then finally, I think that as both of you mentioned, that we need to continue to better understand the variables and potential differences in biology that led to slight increases in complication rates. What is attributable to comorbidities, to fundamental differences in how we might be treating the patients and the techniques that we're employing to improve the safety profile for the women that we're treating with CTO techniques. So really a important manuscript for our patients and for our field. Thank you so much.